Okay, hello, welcome. I'm Jacqueline Kish. I use pronouns she, her, and to provide an image description of myself, I'm a white woman with short dark hair, tortoiseshell glasses, and a white tank top.
I'm Amy MacArthur, and I use she, her pronouns, and my image description is I am a white woman with brown hair, glasses, and my hair is pulled back.
Okay, so we're members of the OT and Disability Studies Network. Our presentation today is the result of a collaboration with a group called the Occupational Therapy and Disability Studies Network. The mission of this group is to create and disseminate knowledge, integrating contributions from disability studies into the field of occupational therapy. We do this through critical reflection and collaboration with occupational therapy practitioners, scholars, educators, and students, as well as community members to broaden the profession's understandings of disability. The presentation that follows was developed collaboratively, and they reflect professional experiences as OTs and disability scholars. It's also informed by our collective research and our connections with the disability community. The material presented here is intended to provoke thought and consideration by OT students and is not exhaustive of all possible perspectives. This presentation is not meant to pass judgment on the case that we'll be presenting or affiliated family members, but rather to ask healthcare providers to recognize that life with a disability is viable and valuable when we're presented clinical decisions, when we're speaking with patients and their support systems. So thank you for taking the time to engage with Timothy Bauer's case with us. Just a content note before we proceed with the presentation, that this discussion mentions death and removal of mechanical ventilation. We're hoping to provide you with some additional information about how you can bring anti-ableist perspectives into clinical and ethical reasoning as future occupational therapy professionals. We're going to be providing image descriptions throughout to increase accessibility, and captions should also be seen on this video. The title slide is called Ethics Case Study, and it has a logo of the Occupational Therapy and Disability Studies Network, which is made of a red and blue overlapping circles with OT plus DS text below, and it reads Occupational Therapy and Disability Studies Network. In this recorded lecture, we'll touch on 6 distinct areas of content, and these are listed vertically. The first is disability and autonomy. The second is opportunity for OT. The third is talking about what actually happened in this case. The fourth is commentary from Not Dead Yet, a disability organization. And then the fifth is defining the disability paradox. And then finally, takeaways from this case. I'm going to hand this off to Amy.
So the first topic we're talking about is disability and autonomy. And we'll start with the definition of autonomy according to the AOT Code of Ethics. So the principle of autonomy means that occupational therapy personnel have a duty to treat the client or service recipient according to their desires within the bounds of accepted standards of care and to protect their confidential information. Often, respect for autonomy is referred to as the self-determination principle. Autonomy can be complex within healthcare decision-making. Often autonomy is highly valued within healthcare settings. However, for someone to make an autonomous decision, it is important that they have access to all the relevant information and knowledge that can inform this decision. Many people that experience an acute medical event may have little to no knowledge of the possibility of living a good life with a disability. Oftentimes in society, disability is represented as bad or sad rather than a potentially positive experience. If someone has not been exposed to positive experiences of a disability, they may be less likely to choose a course of medical treatment that would result in a life with disability. With an acute injury such as the one experienced by Mr. Bowers, it is difficult for both healthcare providers and the patient and their families to know exactly what the future will look like in terms of occupational performance and health. His future is largely influenced by medical management of his injury, rehabilitation, and training on adaptive strategies and equipment, in addition to the environment he lives in, social supports, and a variety of other factors that come into play. So next, we're going to move to talking about opportunities for occupational therapy within a case such as Mr. Bowers. So there are multiple different actions that an occupational therapy practitioner could take in a case like Tim's. This is not a comprehensive list of all the actions, but rather a few ideas that we've come up with that may be relevant. Many of them do not provide direct intervention, but may have an influence on his clinical outcome. The role of OT following a spinal cord injury such as Tim's is highly dependent on how the recovery process unfolds and on the resources available. So the first opportunity that we'd like to discuss is an ethics consultation. So many hospitals and healthcare systems have healthcare ethics resources that assist clinical providers in navigating ethical concerns or dilemmas. This may include the availability of healthcare ethics consult service. According to the organization that certifies healthcare ethics consultants, healthcare ethics consultation is a set of services provided by an individual or group in response to questions from patients, families, surrogates, healthcare professionals, or other involved parties who seek to resolve uncertainty or conflict regarding value-laden concerns that emerge in healthcare. Healthcare ethics consultants differ from other healthcare providers in that they have been assigned by their institutions the distinctive role of responding to specific ethical concerns and questions that arise in the delivery of healthcare. Healthcare ethics consultation is often performed in conjunction with other healthcare ethics activities, such as educating healthcare professionals, developing organizational policies, or serving on organizational committees. In this situation, the occupational therapy professional may initiate an ethics consult or collaboration with the ethics program to help guide the clinicians involved in the case on navigating the plan of care. Another opportunity for occupational therapy is patient and family education. Because Tim's exact prognosis is unknown, education should include the role and possibilities of rehabilitation. This might include occupational therapy's role along the continuum of care in places like acute rehabilitation and his home or community. While exact interventions will be targeted to Tim's progress as he recovers, intervention can take place at the individual level, the activity level, and at the environmental level to adapt his living situation and provide appropriate community supports. For example, OT can help anticipate a shift in life responsibilities to becoming a father, including role adaptation, how he might contribute to childcare, and ways to modify his environment to engage in childcare. Next slide. The next opportunity for occupational therapy we want to discuss is exposure to positive disability experiences. So although this may not be commonly included in OT intervention within acute care, taking a moment to expose Tim and his family to a variety of disability experiences can provide them with more information to aid their decision-making. They may never have known someone who was in a wheelchair, or they may have limited understandings of what life might look like after a spinal cord injury. Exposure to experiences of other individuals with spinal cord injury at different phases of recovery could highlight community living outcomes that are positive. OT approaches to this exposure could include a formal peer mentoring program if that's available at your institution, or the use of social media accounts that portray the realities of life after a spinal cord injury. I do want to caution you to not provide an exceedingly optimistic prognosis that might be unrealistic or unknown for Tim and his family members. Additionally, it may be helpful to avoid videos that portray celebration of people with disabilities for doing daily tasks like walking or getting out of bed on their own. These videos can perpetuate the idea that disability is something to overcome in pursuit of what is perceived as normal functioning. The next opportunity for occupational therapy we want to cover is communication. So in the description of Tim's communication about his desire to remove mechanical ventilation, he noted it as a means of communicating his preference. No details were provided in the publicly available news coverage about his ability to comprehend information or communicate given his state of acute illness. Other multidisciplinary team members may be best equipped to assess speech and cognition, like a speech and language pathologist. In acute care settings, SLPs typically assess cognition, speech production, understanding, and may be appropriate to consult in Tim's case. Encouraging a referral to speech before a decision is made can help include adaptive approaches to communication that match Tim's ability to move or respond. The use of adaptive communication methods can help assure that patients are fully informed and able to express their desires in treatment decisions, especially around end-of-life decisions. Next slide. Jacqueline's going to tell us a little bit more about what happened in this case.
So now that you've heard a little bit about the opportunities for OT in this specific case study, I want to just briefly discuss what actually happened in this case. So the news article that we reference that you've already been introduced to, it talks about how Tim's family asked doctors to revive him from medical sedation so that they could tell Tim his prognosis. The family said, "We just asked him, do you want this?" And Tim, shook his head emphatically no, said his sister. So life support was removed that day and he passed away. This is a case that has received attention from the disability community, and we wanted to discuss with you the response from an organization called Not Dead Yet. Not Dead Yet was established in 1996 and is a national grassroots disability rights group that opposes legalization of assisted suicide and euthanasia as deadly forms of discrimination against old, ill, and disabled people. They seek equal protection from the law to preserve life for those whose lives are seen as worthless. So in Tim's case, John Kelly, the New England Regional Director of Not Dead Yet at the time, provided commentary on this case to the National Council on Disability in 2013. And the following is an excerpt of what he said. So he said, Tim Bowers deserved to get the same suicide prevention services offered to any other person in the throes of trauma. Instead, he was given an incomplete and hasty prognosis and false certainty of future suffering. No one told him about all the opportunities open to him or about the adjustment and adaptation that follow in time. He went on to say, I have almost exactly the same injury as Bowers, and I know that reliable prognosis requires the passage of time. In the spinal cord injured community, we know people who weaned off ventilation. We also know many people who have led thriving lives with breathing assistance, whether by ventilator, oxygen, or continuous pressure, CPAP, or BiPAP. Based on this misinformation from doctors, and his loved ones' fears about life in a wheelchair, Tim Bowers gave his consent to dying on the first day after his injury. In no way was his decision based on informed consent. I think it's clear from Mr. Kelly's comments that he believes a decision made as quickly as the one in this case is not indicative of fully informed consent, and that individuals with acute medical conditions should have the opportunity to understand that life with a disability is valuable.
So next, we wanted to discuss the disability paradox, which is relevant in a case such as Tim's. So the disability paradox describes the phenomenon of people with disabilities often ranking their quality of life as good or excellent, despite commonly held societal perceptions of life with a disability as bad or indicative of a lower quality of life. This might be because it's hard to imagine what life could be like with a disability or chronic illness without actually experiencing it yourself. Interestingly, literature suggests that people are adaptable in the face of injury, illness, and disability. They adapt both emotionally and pragmatically to new situations, resulting in a better quality of life than they may have initially anticipated. Even if people say, I would never want to live with something, they may change their minds when they are actually in a position to live with that circumstance. In addition to research showing that people with disabilities often report higher quality of life than would be anticipated, there are studies that show that healthcare providers are not very good at predicting what a patient desires and believes. This is especially important because clinicians may reflect on what would I want if this happened to me or a family member to help guide their care delivery and encourage patients to make the right decision in a clinical circumstance. However, reflecting on what we as clinicians would do is a more accurate representation of the biases or beliefs that may influence how we deliver care than what is necessarily in the best interest of the patient that we are serving or treating. Rather than attempting to predict or guide patients to what we feel is the right choice, it's important to equip patients and families with the information and skills necessary to make informed treatment decisions based on their own preferences and values. I'm going to hand it back over to Jacqueline to wrap up the case.
So I'm just going to wrap up today. Our main takeaways here is that we hope you get from this case study activity is that the role for occupational therapy practitioners and providers is to value people, their ability and strengths, regardless of disability status. OT practitioners should play an intentional role in promoting occupational engagement for all. For some people, independence may not be the goal. And even if it is the goal, achieving it may not be the only contributor to their quality of life. Living interdependently with supports from others and alternative means of accessing occupational engagement can help people to obtain care and achieve life goals and satisfaction. Accessing occupation with the support of other people or assistive technology should not be framed as negative within healthcare spaces, but rather as a means of engaging with the world differently. Hopefully, this presentation provided you with varied perspectives and considerations about disability that you can bring into your clinical practice. To wrap up, I just want to repeat again that this presentation is not meant to pass judgment on Tim or his family members, but rather to ask healthcare providers and you as future OT practitioners to recognize that life with disability is viable, it's valuable when we're presenting clinical decisions to patients and their support systems. So thank you so much for viewing this presentation. Our contact information for the OT and Disability Studies Network is on our website. If you have questions or feedback for us about this video, thank you.